Good evening, everyone. Hey, this is Dr. Dennis Patterson with the Pacific Spine and Pain Society, and we are getting excited to have our annual meeting in about 1 month, actually, from today, September 17th. And part of that is over the last several years, I've been doing an APP course, and traditionally we do some APP run webinars prior to the annual meeting to hopefully recruit wonderful APPs, whether they're working in spine, pain, or anything in the field of either, to come join us at the annual meeting. Tonight is the webinar that we're going to do, hopefully to get people more involved with PSPS, attend our annual meeting. And first and foremost, I want to thank Nevro for being a wonderful sponsor for tonight's webinar. And I have to say, I am quite impressed with their DPN data and the results that I've had with patients. And so I asked them if we could do one on HF10 and DPN. I figured that kind of rhymed, or PDN. It just kind of comes off nice off the tongue. Tonight I have Zora, one of a wonderful APP from the University of Kansas City. I've got Megan, also another fantastic nurse practitioner from New Jersey, and Jill, who works with me in Reno, Nevada, joining me tonight. Tonight, we're going to kind of cover the topic, kind of talk a little bit about the mechanisms of action and indications for HF10. Then we're going to delve deeper into the diabetic neuropathy data, and then we're going to follow that up with kind of the future, AI getting involved in medicine, and how Nevro has really taken that by the horns and actually got a lot of data over the last decade on patients and how we can better program their patients. Then we'll do some Q&A. So if any of you out there tonight would like to ask any questions of myself or any of our wonderful speakers, please just put it. I will moderate that at the end. And then we'll also have some closing remarks. But before we get to tonight's topic, we've got a slide. As I was promoting earlier, our annual meeting in Las Vegas at the Venetian, September 17th through September 20th. I say it's really actually the 18th through the 20th, but I'm getting there the night of the 17th. And we'd love to have people come. So please get out your phones, use the QR code. If you missed your chance now, I'm going to put this up at the end of the presentation as well, so you'll have a second chance to get it. Next slide. I just also want to highlight our PSPS annual conference agenda. You can see it's pretty robust. It's going to be all day. It's the Thursday, the 18th, and we have many topics that we're going to talk about. From bread and butter stuff to more advanced procedures, and some panels talking about different cases on how different people would handle it, whether it's a spine group seeing a patient or an interventional pain, and how we can collaborate and work better together. And with that, next slide. We are going to transition to our slide deck tonight. Zora is going to be our first speaker. I've asked her to talk a little bit about the mechanism of action of HF10 and the current indications that the therapy is good for. Zora is based out of the University of Kansas City. She works with Dawood Syed and Dr. Latif, two well-known names in the interventional pain community. I've seen Zora present multiple times. She is absolutely fantastic. You guys are in for a wonderful treat tonight. And thank you, Zora, for being here. And with that, I am going to turn it over to you.
Awesome. Thank you so much, Dr. Patterson, and to the team from PSPS for allowing us to be able to help spread some knowledge, bring some pain education to our APP fellows. So welcome everybody to the call. I have been fortunate to be able to work with a great team to learn a lot and be able to educate on the forefront for APPs. And one of my favorite topics, actually, with a lot of what we do in pain management is spinal cord stimulation, especially with high frequency stimulation. So I'm honored to be here, and hopefully we can share some knowledge with you guys tonight. So I think the more core of what we're trying to help with understanding in frequency and high frequency specifically is differentiating how Nevro, the high frequency therapy works. So one thing that I think is really important is understanding what does high frequency really mean. And so I think the biggest differentiating factor with the high frequency system that Nevro has is the specificity of dorsal horn stimulation through 10,000 hertz. So when we're talking about frequency, traditional spinal cord stimulation essentially is a paresthesia-based therapy where the dorsal column is being stimulated, and we're trying to essentially quiet down the pain intensity by stimulating dorsal column fibers. And when you look at this graphic, I think it's important to note that high frequency from our competitor therapies that are out there essentially are anything that's around 1,000 hertz or 1,200 hertz. So anything that's up to 1,000 hertz is considered high frequency with traditional spinal cord stimulation. But the high frequency we're talking about that's uniquely different in the Nevro mechanism is 10,000 hertz. So if you look to the right of the graph, we see that much more potent, basically, frequency at 10,000 or 10 kilohertz. So essentially what happens is at 5,000 hertz is when the mechanism really starts to change, and we're actually targeting the dorsal horn of the spinal cord. So stimulation becomes now paresthesia independent. So we're not essentially relying on the sensation of vibrations to help a patient quiet down those nerve fibers. And so essentially that's the primary difference that we see with the spinal cord stimulation that Nevro offers with 10,000 hertz. So again, key thing from this particular slide to understand is the lower frequency, less than 1,200, and anything below that is traditional spinal cord stimulation, which can be termed as high frequency, but definitely a differentiator from 10,000 hertz, which is patented to the Nevro therapy. So as we think about this concept and how that mechanism really changes, I think we have to understand, obviously, the pain pathway and gate control theory. Of course, hopefully, most of you that are on this call understand how pain signals are perceived and how our brain responds to these inputs that we receive. So we talked a little bit about dorsal column, dorsal horn, the fibers that are basically the controllers that when we feel a perception, signal to our brain a response, right? And essentially what happens when we stimulate patients is traditional stimulation really depends on dorsal column activation, which is that gatekeeper essentially to allow us to feel or perceive signals of pain. And those paresthesias are essentially what we feel in basically opposition to the pain. So we have to really link these kind of stimulation therapies or these vibrations basically to how we would calm down the perceptions in the brain. So essentially this is the mechanism of which we feel a perception, those signals go to the brain then responds by the paresthesia that we're feeling to hopefully inhibit those sensations. And it's really dependent on where we place those particular nerve stimulation leads. If we can go to the next slide, we can kind of talk a little bit about how traditional spinal cord stimulation revolves around where we place the leads to help get the coverage the patient needs. So essentially, we're trying to place a anatomic lead to a specific location to help target an area of pain that the patient may be having. So whether it's back pain, leg pain, something in between that region, or if it's an upper level, we're trying to put these leads in a place that dermatomally covers the region that the patient might need it. And then that specific paresthesia will then hopefully target the zone, whether it's the right side or the left side, and we kind of map that when we're putting the device in. So essentially, the more paresthesia coverage you have, hopefully you have more pain relief. So essentially, that's kind of the requirement in traditional spinal cord stimulation to be able to achieve pain relief, where during the trial or during the implant, the physician is actually trying to stimulate the zones, talking to the patient through the trial, asking if they feel in a certain distribution, and then hopefully placing it based on that. Next slide, please. What we can see, though, that Nevro has been able to achieve for us in the advent or innovation of their technology, essentially, is that we're going outside of that paresthesia world to help improve patients' outcomes. So essentially, when we talk about a paresthesia independent system, we don't have to find that location during implant, test the patient, feel the stimulation, and know that we're in the right place. We're essentially then eliminating that need because we can anatomically place these devices in the distribution zone that we know typically covers that patient's region of pain. So it's a fairly increased or enhanced way, especially for our physicians, to be able to place the leads. You're not having to wake up the patient, so there's less time with placement. And that unique action that occurs when we go higher in the frequency settings, where patients then start to feel that neuronal inhibition happening, also helps patients to feel relief without feeling a paresthesia. So again, it's a unique mechanism. You're not having to feel a sensation or vibration. The placement of the leads are anatomically placed, so we kind of know where we're going before we even start. And we do have significantly good data and outcomes in the research that is clinically superior to some of the other data, which we'll look into a little bit on a later slide. These patients' response rates are significantly good. So when we look at how many patients are responding, at least 50% relief, the benefits are significant for these folks, 70, 80% of a response rate of these patients. So when we look at some of the traditional usages for spinal cord stimulation with back pain, lower extremity pain, we're seeing numbers that are up in the 70, 80 range. And as we'll discuss a little bit later, that Jill will review, the PDN or painful diabetic neuropathy patients scored even higher on a response rate for the 24-month data that we have. So really finding significantly higher outcomes, particularly with high frequency 10,000 hertz. So again, just kind of looking at the data, understanding the mechanism and the benefits of having a paresthesia independent system coming all together to help provide patients outcomes. Next slide, please. So why does frequency matter? So a little bit more into that original graphic that we had. This slide takes a look at the various studies that have been done over time where certain therapies are stimulating at a certain level of frequency. So as I mentioned earlier, on the left of the graph, you have anywhere from 1200 hertz and lower. And then on the right side, we see the studies that Nevro invested in for back pain and the larger scale back and leg symptoms that patients were having with the Senza RCT. So when we look at the evaluation, right, of patients' responses, who the response rate being if a patient had 50% or more relief, we're looking at a significant difference, right, in the patients who had a high frequency neurostimulation therapy as compared to traditional stimulation at 12,000 hertz or less. So the unique difference here is that at 5,000 hertz, as the graphic shows, you increase that neuronal inhibition because we're now stimulating at the dorsal column, which gives us a wider range of stimulation for pain control, essentially. If we were to do that with a lower frequency setting, the problem is that patients then start to feel adverse effects overstimulation. But with 10,000 hertz, we're really able to prevent that and give them much better outcomes on their response rate, as you can see, 79, 74, and 79 respectively on the studies, as compared to less than in the 50% range with the traditional stimulation settings. So again, just a visual graphic of why that frequency number matters, and that high frequency really does refer to 10,000 hertz. Next slide, please. And then again, we have additional information with regards to data showing that patients who have high frequency stimulation definitely do demonstrate long-term relief. These are for patients who've had back and leg pain, and the response rate we see across time. So initial timeline through 24 months. In the blue line on the top are the patients who have had a high frequency neurostimulator, and that 10,000 hertz has sustained anywhere from 75 to 80% relief over the course of the 24 months. As compared to, of course, traditional stimulation, which works, but the efficacy we can see definitely is statistically stronger with the Nevro therapy. So with that, that kind of gives us a summary of what the high frequency setting, the mechanism is that's different. Go ahead and go to the next slide, please. Thank you. But what we can kind of see additionally is the versatility of what makes the high frequency unique. So when we look at what options can a patient essentially have in a spinal cord stimulator when it comes to an HFX device, the versatility really is optimized. And we can say, typically I'll tell a patient, I don't know that we can say we've tried true spinal cord stimulation until we've had the option to do high frequency or low frequency, because some patients may actually respond to a paresthesia-based system. Not often, but it is an option where patients might need that. So the nice thing about high frequency stimulation therapies are that you can actually do low frequency if you so choose to. Most patients, again, don't. But we can mix or combine or pair frequencies with patients who have an HFX system and do different modalities. Whereas in the competitors, unfortunately, the high frequency 10,000 hertz is patented. So that's something that's not available in some of the other devices that exist. Next slide, please. Again, kind of just going back to the options that exist for patients to have versatile programming options is available. But as you can see, based on this slide, of the 84,000 patients that they have so far been able to get the data on, which is essentially every patient that is data is basically being collected from every patient that has these devices through the company. The majority of these patients essentially are using the high frequency setting. So 96% of these patients have the high frequency setting. Some do paired. There are a few that have a burst or a low frequency, but the majority of patients really like the high frequency. They don't have to feel any vibration stimulation, and they continue to get good outcomes from that. So in a nutshell, essentially, we're seeing that the high frequency really does work well for these patients. They continue to use that treatment to give them the outcomes that we see that were very similar to what we saw in the studies that were displayed earlier. Next slide, please. And we'll move on to some of the more key data with the painful diabetic patients, and I'm going to let Jill take over on this one. Thank you.
Perfect. Thanks, Zora. I appreciate you presenting on that data tonight. That was awesome. I appreciate it so much. And right now there's no open questions. I just want to remind everybody, if anybody has any questions that they want to throw out to any of our speakers tonight, please write it in the chat box. I'd be more than happy to moderate. If not, I'll kind of create some robust conversation coming up. Our next speaker is Jill Studi. She is from Cleveland, Ohio, got involved in pain management, working with Paul Lynch and Tori Madronkin at Arizona Pain Specialists. I was kind of fortunate enough to steal her to come to Reno, Nevada to work in my clinic. We've been working together for several years and feel fortunate to have her with me and have her speaking tonight about our experience with HF10 and diabetic patients. And thanks for joining, Jill.
Perfect. Thank you so much for that introduction. Wonderful job, Zora. I just love how you explain everything. And thank you everyone for coming out tonight. Hopefully we get to see you all at PSPS here soon. So I am going to delve in to kind of the nitty gritty on one of those 3 Senza studies that Zora was talking about. So specifically tonight, we're going to be talking about painful diabetic neuropathy, Senza randomized controlled study. So essentially, there are millions of patients diagnosed with diabetes. I'm sure many of you probably have, family members or may have, or certainly know someone, a friend, family member that has diabetes. So there is at least when this data was taken, there are about 29 million patients that are diagnosed with diabetes. And then out of those 29 million, about 20% have or experience painful diabetic neuropathy. So that estimates out to about 5.7 million patients with painful diabetic neuropathy. And then out of that, then about 45% of those patients are refractory to conservative medical management. meaning that they do not get therapeutic relief from trialing those medications. Next slide, please. So as far as what kind of our normal treatment algorithm in medicine right now is trying pharmacologic options. So whether that's oral medications or topical medications. So we have our anticonvulsants or your pregabalin, your gabapentin, your SNRIs or your duloxetines, and then your TCAs, your amitriptyline, your nortriptyline, as well as topical treatments. So those are going to be kind of first line for those diabetic patients. And like I mentioned, about 45% of patients that try these do not get any relief with these options. So at this point now, high frequency stimulation is and has been FDA approved for painful diabetic neuropathy since July of 2021. Next slide, please. So as far as the medication management, I'm sure most of you have tried, these medications for your patients. So typically, algorithm is usually, trying a gabapentin. And then, most people then switch over to Lyrica or pregabalin, then maybe Cymbalta, amitriptyline. So with those medications, there is, for every medication, there's a number needed to treat versus a number needed to harm. So the best way I like to think of this is 1 out of X. So essentially for gabapentin, we'll just use that since it's at the top, 1 out of 6.3 patients need to try gabapentin in order to get treatment or get some benefit from it. Inversely, 1 out of 25.6 patients need to be treated in order to have a side effect. So typically, if we kind of go down to Cymbalta, essentially 1 out of every 11.8 patients is going to have some sort of side effect from that medication. So that's a very high number for especially, most of us see a vast majority of, number of patients as APPs in clinics. We see a lot of them and treat a lot of them. So the number needed to treat is unfortunately pretty low, whereas the number needed to harm is higher than ideal versus, some other treatment options. And then, with that comes the patient adherence. So another huge, essentially hurdle for us as APPs is to get patients to not only try a therapy that we recommend, but also continue with it. So on average for pregab and for gabapentin, after 1 month, about 33% of patients discontinue. And that goes up to as high as 60% after 6 months. And then duloxetine is similar numbers. So after 1 month, about 25% of patients have discontinued. And then 50% of those at 6 months have discontinued. So a really high, let's say a low number needed to treat, a high number needed to harm, and then unfortunately, that most patients end up discontinuing these medications either under our guidance or on their own. And then a lot of these patients that have been discontinued don't typically end up switching to an alternative and typically leave their condition untreated. Next slide, please. So this study that we've been kind of starting to talk about is the largest randomized controlled study for painful diabetic neuropathy with high frequency. So it's 216 patients across 18 different US centers. And they put them in, these patients were 1-to-1 randomized in either conservative or conventional medical management versus high frequency stimulation along with conventional medical management. So it was 1-to-1, and then at the 6-month mark, essentially then patients had the option to then cross over into the high frequency treatment algorithm. And out of that, 93% of patients ended up switching over to the high frequency stimulation option. So when they were looking at these patients, realistically, they not only chose a robust or a large amount of different centers, but they really targeted, I feel like, our normal patient population. They didn't pick, the cream of the crop patients that might not have many comorbidities or might be, just an easier population to treat. So with that, they chose obviously patients that had painful diabetic neuropathy, that had tried and failed 2 medication classes. One of those had to be a gabapentinoid, and then another drug class. So patients had already tried and failed 2 medications. And then on top of that, they had to report at least a 5 out of 10 on their pain scale, their BAS pain scale specifically, and then had a hemoglobin A1C of 10 or lower, and then a BMI of 45 or lower. So again, I really appreciated this study in the sense that they really did a large number of patients that I typically see every day, day in, day out. And this is a high volume of the patients that we normally see in pain practices. Next slide, please. So these are 2 comparison charts. Essentially, you can really see the difference from the chart on the left versus the right, as far as the implanted patients versus the conservative or conventional medication management. So on the left, the biggest thing with this study is that it was really showing longevity. So it wasn't that they implanted and checked at 3 months and then, wished these patients well. They really kept up with these patients for the next 24 months. And the numbers continue to be consistent throughout those 24 months. And then comparing to at 6 months, they did take a look at that conventional medical management. And you can see that kind of inverse relationship right there where they actually had a 2% increase in pain rather than a reduction in pain. Next slide. So what Zora was mentioning earlier is that high responder rate with this study. So this really blew the water for other studies that had been done on stimulation. And again, that longevity of 24 months. But they had a 90% responder rate. So what that means, and the numbers are on here, is that 128 out of 142 patients, so 90% of the patients in this portion of the study obtained over 50% relief. On average, patients got about 80% relief. So really kind of taking that norm of 50% and really excelling and changing that kind of new normal for us and for our patients. And then there was also a 65% profound responder rate. So patients that actually got 80% or above pain relief. And then to circle back, so if we recall a couple slides ago, we were talking about the gabapentin, just because it's the sake that most of us have used or our patients have tried. The number needed to treat was 1 out of 6.3 patients in order to get a benefit out of it, whereas the number needed to treat for high frequency stimulation for painful diabetic neuropathy is only 1.3. So a very 1 out of every 1.3 patients gets benefit. So a really, really high responder rate from this study. Next slide, please. So along with not only the kind of typical VAS scale and patients kind of having to say essentially a 0 out of 100%, how are they feeling in that exact moment. What this study also did is took a look at the actual neurological symptoms and those improvements. So not only the pain and how patients kind of experienced in that sense, but also the symptoms of numbness, tingling, burning, and that cold sensation, and how much those drastically improved over the 24-month period. So I really like on the left this color coordinated scale for us to really visualize how much those symptoms decreased for these patients over that 24 months. And next slide for me, please. So with this study, now we have multiple other collaborators in medicine that are now recommending high frequency for their patients. So the American Diabetes Association in their 2022, as well as the American Association of Clinical Endocrinology in their 2022 practice guidelines, did recommend high frequency stimulation as a non-pharmacologic treatment option for these patients. Next slide, please. So those two, as well as in 2023, the Worldwide Initiative for Diabetes Education also recommended high frequency, in essentially stating on the bottom there that's showing strong efficacy and improvements in quality of life, which is one of the biggest things for our patients, is how they're able to function and go about their daily activity. So quality of life is so important. So I love that they really highlighted this in their consensus statement. And then for those of us, who are familiar with the American Society of Pain and Neuroscience, they also did put this in their guidelines for painful diabetic neuropathy as well. Next slide, please. So when you're, looking, in your day-to-day in clinic, a lot of these patients, just keep in mind they're likely already in your clinic. So make sure to take a look at that past medical history, or if they're not good at putting, I know my patients are awful at stating their past medical history, but for the most part, they'll put some of their medications or their other doctors names kind of in their paperwork. So just take a quick glance, see if they're on medications for diabetes. Also take a look at their gait as they're kind of walking in, or if they're saying that they're falling a lot because they're not feeling their feet. So just try and take that extra couple minutes, especially with new patients, when you have that extra little time to look through their medication history and their past medical history and see if they are diabetic. And if so, ask them a couple questions on, if they hit that criteria for diabetic neuropathy. And then essentially if they have tried and failed 2 or more medications, and then, take a look at that VAS scale. If they have an A1C less than or greater to 10, and or symptoms like we talked about, that numbness, burning, tingling, or the cold sensation, and make sure that you're kind of putting that in the patient's treatment algorithm once you've identified them. Next slide, please. And then also keep in mind that these patients, they are different than our back pain patients or our ortho patients, in the sense that you may be saying pain, and they may not identify it as pain. They may identify it as not being able to feel their feet. Or just saying, I don't have pain, I just can't feel anything, can't feel my feet, or it feels like numbness and tingling or pins and needles, so make sure to just ask all those questions on how they might think of that as not just pain, but other changes in their proprioception as well. And then taking a look at, how much not only it affects, their pain, but also, their sleep, how they can get around, their ability to do daily tasks. So just make sure you're kind of going through those originally. And then when you're working them up for stimulation, make sure to set really appropriate expectations for them that those are kind of really big functional and quality of life improvements that we really want to monitor very closely. And like I mentioned, they have typically, maybe have not had a large surgical procedure before. So just make sure to really take the time to delve in on the ins and outs of trialing a stimulator and kind of what they're expecting. And then as well as the implants, so they know how to navigate that process, since it is very, very different to go from just trialing a medication to proceeding through with an implant. So just make sure, as a little synopsis, just kind of work these patients up, make sure to kind of, take them through what to expect and how this is different than the things that they have tried before. And I always tell my patients, it's absolutely worth trialing. You know, if anything, have them at least do the trial to see if they are an appropriate candidate or not. Next slide, please. All right, I think that's a wrap for my end here.
Perfect. Thank you, Jill. We do have a question, but I'm going to hold it till live for all panelists at the end. So don't worry. I see your question and we will address it. The next, we have another fantastic APRN from New Jersey. You win most committed tonight, Megan.
Most committed.
Yes, because it's after 10 o'clock there, and God bless you for participating and being willing to do this. So thank you so much for your dedication. I know you've been educating other advanced practitioners for 25 years. You're involved with the North American Neuromodulation Society and working on the committee for APP education. You're currently at Everpoint with Dr. Winnie, Dr. Welsh, and Dr. Rudman. And so thank you so much for coming on tonight. And thank you for leading this AI discussion on programming that Nevro has come up with. I figure it's always good to hear what the current future is right now. So thank you.
Sure. Well, thanks for having me. I'm really excited to be here. I love connecting with other APPs, even if we're just doing it virtually. I will put in a little plug here. I haven't been to the PSPS conference yet. But if you haven't been to a conference that really has a program set aside for APPs, I would really recommend it because I have presented with Zora and have her as a friend for a long time. We live very far apart and we only meet at conferences, but it's really great to have people you can kind of touch base with and run ideas off of. So that's my little get involved plug. But I am excited to talk about high frequency stimulation because we use it a lot in our practice and it has really been a game changer. So what we're going to talk about now, we saw how it works. We saw how it's different than traditional or low frequency stimulation. We've seen the really impressive data regarding painful diabetic neuropathy, which is really amazing for anybody who's worked in pain management for a long time. We've had like almost nothing to offer these patients. So to have it be such profound relief with such a low number needed to treat, it's great. So then what happens? Everybody's like, yeah, but what about the details? What about like, how hard is this thing going to be? Like, what do I have to do? Is my mom going to be able to use it? Do I have to have a neuroscience degree to make this thing work for me? And so we're going to talk about that a little bit, and we're going to talk about the data, the combination of the data, the scientific data, and the real world data that Nevro's been collecting. Next slide, please. So this is just a little timeline. I have been doing pain management for a long time. If you're new to pain management, you might not really understand how Nevro kind of shook things up. So prior to 2011, we were using spinal cord stimulators back in those days, not just opioids. And we would tell people, it's great, we can get your foot covered, we can get your knee pain covered. We probably aren't going to be able to get your back pain covered. That was like our standard spiel. And when they came to market with this new therapy that really had profound benefits for low back pain, it really changed the whole scene. Not only did it work for low back pain and they had better outcomes with that, but it was paresthesia free. So all of those people who were tingling and buzzing and all of these other sensations that they didn't like, there was now an option for them. So what you see if you kind of follow this up is in 2016, they really started this huge database. So they have been collecting data on all of the patients who have these stimulators in place for basically the last 10 years. And what's great about that is you can look at the evidence from the randomized controlled studies, and then you can compare it to real world data. Is it actually reproducible, right? Or like, did they just pick really good people for the trials? Do you ever wonder that? I wonder that sometimes, but it's not that, right? They see that it's reproduced. And what this has also done is it's given us a huge amount of information as to what works for what for most people. Then they moved up, right? They're like, okay, we got that. We kind of cornered that. Now we're going to move into some of these other spaces. So we had been using spinal cord stimulation off label for diabetic neuropathy prior to 2021, but it was almost impossible to get it approved. And, you know, we were kind of doing it based on, uh, you know, what seemed to be a good idea. Obviously, it's better if you have data. So they came out with this big Senza PDN trial, and then they came out with this non-surgical low back pain data. And again, if you're newer to the space, you might be like, of course it works for back pain, but this is not something we always had evidence to support. So they keep kind of pushing the ticket. And now we're at this place where we have this AI enabled IPG, which is just for anybody who's new to this, that's just the battery, right? So the battery is now this AI enabled. So let's talk about that a little bit because some people think it's scary. It actually has made the use of these much more effective and much more patient friendly. Next slide, please. So this is what it looks like. I think one of the benefits or positive unforeseen outcomes of the pandemic is people have gotten a lot better at using smartphones. So there's always this question, you know, but what about my elderly patients? My elderly patients use this just fine. If they can FaceTime their grandkids, they can do this. So this is what it looks like. They start, if you look at the little thing on the all the way, well, on my screen, it's all the way to the left. It will say, hi, Megan, let's do your assessment. Are you ready to do your assessment? And they will hit yes if they're ready to take an assessment. And then it will go through what's your overall pain relief today? What percentage? Now, specifically, what's your low back pain? As you know, a lot of our patients have very specific pain, right? They have the pain in the left buttock, but then they have pain in the inside of the knee, but then their big toe is burning and their heel hurts for some random reason, right? So they have all these different pains. So we'll ask about this. Then it asks about what's your activity? Have you increased your activity? Have you decreased your activity? And it's taking all of this information. Have you changed your medication? How are you sleeping? And based on this, it will either say like, okay, thank you, or it will make a recommendation to change based on how long the program has been in place. So we're not starting from ground zero because we already have all these thousands of other patients that we've collected data from. So we're starting with the best programs, and then we're asking the patient, how are you doing on this program? Now, this might seem like a lot of work. If you have frequent contact with patients who deal with chronic pain, they feel better telling somebody what's going on, right? If somebody says to you, or if you say to somebody, I need your help, and they say, yeah, in a minute, and you say, I need your help, and they say, yeah, in a minute, it's very frustrating. And this is what historically we've had to do with these patients. They call us, they need help, there's a delay, we have to get them in for reprogramming. Now this can all be done on their smartphone daily. So let's look at what that does. Next slide, please. I'll try not to get too excited about all this, but I am actually really excited about all this. That's why I'm up at 10:15 at night. So this is kind of what I've already said, but they start with the programs that have worked, the algorithms that have worked, depending on what the problem is, right? The PDN versus non-surgical back pain. Now, just to mix things up a little bit, what about your diabetic with non-surgical back pain? What do we do then? Well, it will look at that. It will look at, and it will give the patient one program and it will work through. And based on their response, it then may try another program. Now, the really amazing thing, I think there's some other, can you click a couple more times? I think there's some other words on here. Thank you. So what's really amazing is that this bipole interlacing means if they find that program 1 works great for your neuropathy, but program 3 works great for your back pain, it can actually toggle between it so quickly that it's basically like running both programs at once. And this is what's done by getting the patient feedback. The other thing that's really impressive this little relief and beyond, what that's referring to is what happens when all of a sudden the patient starts feeling better and now they're doing more. I mean, this is a good problem to have, right? So they're doing more, but now they may have an increase in their pain. What can they do? They can go back to their app and they can keep taking these assessments, and it will continue to change it so that it can continue to improve the relief. Now, the one thing that everybody worries about is, well, what about the charging, right? I don't want to charge every 5 minutes. I don't want to charge every day. I have bad arthritis of my shoulder and I can't reach my arm behind me, or my mom's not going to remember to do it. She doesn't have somebody living with her. So what is this smart power? What this basically means is once a program is established that this patient is getting some good relief, it can actually switch to pulse dosing. So instead of this kind of continuous dosing, it starts to take very tiny pauses. And what happens is the relief does not change, but it can make do with less and less power requirement. And what they've seen is the majority of patients can actually get down to a very small fraction of the power that they might have initially needed. There's kind of a carryover effect. What does this mean? It means you don't have to charge as often. So maybe you go over to mom's on Sunday and you put it there. Maybe it's once a month. There are even people who only need to do it a few times a year. So obvious that depends on what program they're running, but it's really very easy because all they have to do when they get to their app is that if it recommends another program, they can say yes or no. Yes, switch the program and it will switch. Or no, I want to keep it on this program. And people do that. It gives them kind of the ability to have some control over what's going on. Next slide, please. So the other thing that's great with this is that there is real-time engagement. Sorry, just if you could click a couple more times. Thank you. Oops, yeah. So the one thing I just kind of want to point out here, some of this I've already said, but there can be this proactive intervention. So if they log on and they're not having relief, or if something is going on with the device, there is an alert sent to the Nevro coach, and somebody will reach out to them within 24 hours. So that can be really helpful. It's not, again, this call the office and get an appointment, so on and so forth, so that they can get back on track faster and not run into problems. Next slide, please. This is fun. This is a report that you can get based on any one of your patients. I like to do this when you think, how you have those days where you're like, hey, I haven't heard from Anne in a while. I wonder how she's doing. You can actually go on if this is somebody that you've implanted, and you can see, like, is she charging? What's she reporting her relief to be? The other thing, if you look at this second point here about identifying patients that are non-compliant or not responding to treatment, I just want to say a word about non-compliant. Non-compliant always sounds kind of like judgy and like they're doing something wrong, right? But there are people who forget, or there are people, who think they're doing it. It's like me eating right, right? I think that I'm eating right. And then you ask me to tell you what I've eaten. And I'm like, oh, well, except for yesterday, right? So these patients don't understand why they're having increased pain. And we can identify, oh, hey, listen, you haven't taken the assessments. You saw this drop and we didn't change programs. So it's a great way to kind of give them some feedback. It's also a great way for them to kind of see where they started and see where they ended up. Okay, I'm getting the almost out of time notes. Okay, next slide, please. This is just there. We're keeping the data, we're keeping all of the information so that if somebody says, I'm not really sleeping, we can go back and see on what program were you sleeping. And the device learns as we go along, just like when we shop, and it learns now to show me gel pens before I open any app at all, right? So it's the same type of thing. It learns what the patient needs and it keeps all of that data. So if we need to go back to something or if we want to see what's going on, we can do that. Next slide, please. So what about people who want to talk to people? Nevro is still doing that, right? The thing I like to point out here is that there were 1 million touch points with patients over the course of this therapy. So they're still talking to patients, they're still emailing them, they're still calling them. There are a lot of resources. I think any company that has resources that support us to be able to help more patients you know, it just makes it easier for everyone. And it really ultimately at the end of the day serves the patient better. New slide, next slide, please. Okay, so the only thing I really want to say on here is obviously there's Nevro offers support through the whole thing. What I really like is when I speak on neuromodulation a lot at different conferences, and inevitably somebody comes up and says, "Oh, I have somebody who needs this. Do you know anybody in East Bumble, wherever?" And often, I mean, now I do actually know a lot of people around the country because of things like this, but I can reach out to my Nevro rep and she will reach out to the local rep in that area and they can set my patient up with, or the person that I meet up with somebody locally. So I know we always think of referrals as who's coming in, but I think it's really great that we can actually use this team to help find people get access in the areas that they need. Next slide, please. All right, this is the safety data. I know everybody wants to take a minute and read every little last thing. But
There's
if
going to
you
be
have
a test
questions
on
about
that
safety,
too, right?
it's there. Yeah.
um, yeah. Hey, let me have all panelists come on. Great job, Megan. Thank you for going through that. What I think is amazing about the AI stuff is that when these programs, people are making these choices, they have a faceless, nameless thing making changes and they don't know what change has been done. All they know is that they still continue to feel good. Chronic pain patients are so influenced by words we say sometimes. So say like if their rep met with them and said, "Hey, you're doing so well, I'm going to turn down your energy so you don't have to reprogram that often." I almost in my mind, I see how that could spiral them out of control. Like, "Oh my God, you're turning it down. My pain is going to get worse." And so it's amazing that they don't understand what's happening, but can continue to get pain relief. It'll turn it back up if they truly do, if their pain does get worse. But I think it's amazing now that it's kind of removed the human element or emotions involved with programming. So I think that's fantastic. We got amazing questions here. Thank you, Christopher and Carrie and Alex, for saving me from having to use my corny questions. But the first thing I want to talk about is my site was involved with the original diabetic neuropathy study, and Zora's site was as well too. The one side thing we found out is not only were we helping pain, but potentially we were reversing the disease process because these patients became sensate. Can you talk about that, Zora, a little bit, what you witnessed at your site?
Sure, absolutely. So to the person who asked the question about sensory changes with the diabetic patients, normally as a pain practitioner, I will openly say that I am not taking out monofilament tests and going through when patients come in and say they have neuropathy or nerve pain. It's more of a generalized, do you feel me touching your hands equally and things like that. But in the study with these patients, when we were enrolled, we literally had to do micro or monofilament testing, more specific neurologic testing that I typically don't do in my day-to-day practice. And it was very impressive to see the change when a person would come in and I'd have to sit down and they close their eyes and you would, do the testing along their feet. And initially they felt nothing. I was like really kind of, impressed by the effect of the test. And then they'd come back after they've had their implant and the patients were just like, oh my gosh, the patients were amazed at how well they could feel it. But to be able to actually see that firsthand on these patients when we tested them was very, heartwarming to know that the therapy was helping them beyond just, I'm not hurting, but now I can actually feel the cold floor like I never did before. So that was a pretty impressive benefit that they gained.
Perfect. Thank you so much. Yeah. And, honestly, I think this, as a physical medicine rehabilitation doctor, we realize how much movement is key to life. The more you move, the you're less likely to gain weight, the healthier you're going to be cardiovascularly. And so I think, if these patients, if they have gained sensation, one, they're probably more likely to want to ambulate because they feel safe on their feet. Number two, they don't become a fall risk. We don't want them to fall and break a hip. 1 out of 5 people dies as a consequence of a broken hip. So it's amazing that we can reverse the disease process, maybe help patients lose weight, lower their hemoglobin A1C, get them healthier, the metabolic X syndrome may be able to eliminate that with activity. So sensation is a huge part of that, keeping these people safe and keeping them ambulating. Another question here is, we're talking about neuropathy kind of being a broad diagnosis. We're specifically tonight, keen on diabetic neuropathy, but a lot of times you're going to get these patients that kind of have a mixed bag, right? They're going to have claudication, they're going to have vascular insufficiency. On top of that, they may even have some CLI and they got diabetes with it. They all kind of go together in a roundabout way, especially PVD. Megan, how do you address these patients? Are these good candidates for stimulation, even though it's only stimulators are only approved for diabetic neuropathy?
Yeah, so I think, this is where sometimes it gets a little creative, but I think at the end of the day, we got to remember what the mechanism of action is, right? We're interfering with the signal as it goes from up the brain, up the spine to the brain. So, and having inhibitory changes there. So this is when people are like, well, where are you going to put it and what are you going to do? We're still interfering with the signal, whether it's whatever that signal is coming from, right? And that's why I think sometimes it's really helpful when we're doing trials or when we're talking to them that we're really like isolating out, like, what are we trying to help with this? Is the burning better? Is what's better here? I think the other thing that's important to remember is while the only neuropathy indication is diabetic neuropathy, it's indicated for chronic pain of the trunk and limb. So that's kind of, sometimes we can get it in under that. I know they are doing studies with vascular, now that they've seen this information with all the diabetic sensory data, they're starting to do some studies regarding vascular. But this is it doesn't have a lot of side effects. The people get to try it first. So if they don't see a big benefit with the trial, then we're not going to convince anybody to do it, right? It's either good for you or it's not. But I do think multifactorial just makes it a little bit more fun.
Correct. And that's it. As long as they have diabetic neuropathy, it doesn't matter if they also have some CLI or they have PAD or vascular insufficiency. You still may be able to help those patients, right? We're going to look to help their pain. And if you help those secondary indications, as long as they got one of the primary diagnoses, you should be covered. And
I do have one other, sorry, I have one other
sure.
comment on it. I don't, I know we talked about it quickly with the diabetic neuropathy, but one of the things that I found really impressive with that study specifically was the improvement in sleep. So, it's not like these people aren't getting 1 night of sleep or 2 nights of sleep. They haven't slept for years. And then they're finally getting some restorative sleep. I think it was like 67% or something like that, improvement in sleep. So if you can help people sleep, we can help all sorts of things in their lives. So I think that that's an important part. Sorry, go on.
Yeah. And then, Jill, you talked on the diabetics section, and we know, like you said, the intention to treat with gabapentin or Lyrica is pretty low. You have to treat a lot of patients to have a home run, yet it is seen as like the standard of care, correct? Well, what about, studies now coming out where patients, especially older patients on gabapentin, developing dementia as a side effect of the medication? Do you think that's going to impact our trials, like push, insurance companies to cover them, firsthand or first line, or what do you think that kind of data does?
Yeah, I mean, I'm so happy that Carrie asked that question because actually I was just talking to a patient about that study today. So yeah, I do think that is going to be a game changer as we continue on. But how quickly that will change with insurance companies to let us be able to, proceed forward without adding in, gabapentin as a tried and failed. So that one's a tricky question. But yes, I certainly hope that this does impact it to be more of a first line therapy in patients to not have to go through all those pharmacological options. Or maybe switching it over to, maybe gabapentin isn't the one medication that they have to try for insurance purposes. But I mean, as you guys could kind of see on the number needed to treat and the number needed to harm, the other ones, had a much higher number needed to harm. So it was like, 1 out of 11 patients got harm from another medication. So that is certainly a bigger concern too. Is all of them, aren't perfect, right? All of them have pretty high risk benefit ratios for our patients, which is always what we're trying to really navigate in our space. So I do ultimately hope that we're able to treat these patients sooner, that it's not so much thought of as a last option therapy for them.
Perfect. Thank you. I think Alex has got a couple questions in here. I'll kind of address them since we're kind of at time. He's saying he's a new graduate, and as all new graduates, right, we get confused when we see a lot of patients, and it's like, oh, when do I offer a patient a stimulator? When do I offer them a radio frequency ablation? Alex, to keep it kind of simple for you, usually patients with neuropathic pain are going to be your best stimulator candidates. Neuropathic pain usually is there 24 hours a day, 7 days a week, 365 days a year. It may vary in how bad it is. Mechanical pain or nociceptive pain usually only occurs with movement and gets better with rest. So stimulators help neuropathic pain. So try to find patients that have pain that's always there, that never goes away. Nociceptive pain stimulators don't work that well. So great candidates are going to be your failed back surgical syndrome with chronic, radicular pain as a result of their prior surgery, complex regional pain syndrome, whether it's type 1, type 2, diabetic neuropathy, like we're talking tonight. And then, honestly, there is now, non-surgical low back pain. So those are patients who have chronic back pain that never goes away. They've seen a surgeon and been told that there's not a surgical solution for them. Those are great candidates too. I hope that helps with that question. Then we've got another one. I can answer this one. Is can you salvage other companies' leads by attaching it to a Nevro battery? And this is completely off label, but yes, I have experience with multiple vendors and multiple companies where their leads do fit in the battery, and you jimmy rig it enough and tighten it down to get paresthesia. Just know that that is off label. Once you do that, patients are not MRI compatible. So make sure that it does help. It does salvage things. But, probably doing a full system swap out is probably your best solution than a quick fix. And then a last one, there's a comment here. It looks like probably one of Megan's patients, from Dr. Winnie. It's a patient nurse who has chronic knee pain after having a failed revision or a failed knee surgery, knee replacement, and multiple revisions. And I will tell you that this is a common patient we see. So complex regional pain syndrome type 2, Susan, exists. It's where we have chronic pain in the area where a nerve was sacrificed during surgery, and stimulation works excellent for it. The great part about the therapy is you can try it. So if Dr. Winnie thinks you're a great candidate, you should try the therapy. And then, we always say at my clinic, it's our goal to talk you into trying it. It should be your goal to convince me to implant it at the end of your trial. So you have nothing to lose with trying it out. And I think that's it. That brings us to the conclusion. My shameless plug, please, if you're watching tonight, come to Las Vegas and join us at the PSPS annual conference at the Venetian. Please sign up for our APP conference. It's going to be great. A lot of feedback. We took a lot of feedback from a lot of the attendees last year and tried to shape our agenda this year, specifically geared for what people wanted to see. So thank you guys for joining. Megan, Zora, Jill, I couldn't do it without you. You guys are wonderful. You make my job easy. Thanks everybody for attending tonight. Have a wonderful, wonderful night.